Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, Marcus at Home welcomes Dr. Jolanta Małyszko in Warsaw and Dr. Sabine Karam in Minneapolis in order to discuss cancer treatment in patients with reduced kidney function, which is the title of a recent NDT review written by our guests, which NDT's editor-in-chief, Dr. Anders, Andreas Kronbichler, and I picked as NDT's paper of the month for a Marcus at Home webinar. Dear Jolanta, dear Sabine, it's a pleasure to host the two of you. Dr. Jolanta Małyszko is professor of nephrology and head of Department of Nephrology, Dialysis, and Internal Medicine in Warsaw, Poland, at the Warsaw Medical University, and she is senior author of a recent CKD controversies conference report. Dr. Sabine Karam is associate professor of medicine, nephrology, and hypertension at the Medical School of the University of Minnesota in Minneapolis. She's chair of the Young Nephrologists Committee of the International Society of Nephrology, ISN. And we're happy to have an oncologist as co-moderator from my alma mater in Hamburg, Germany, Dr. Jörg Wittenbrink. So again, welcome to all of you, and we are looking forward to hear from you.
Thank you so much. So here is the reference paper, which I had a lot of joy to be mentored on by Jolanta, Professor Rosner, Ben Sprengers, and Rafal Stek, also an oncologist who works with Jolanta. It was an international and multidisciplinary effort. So today we will recognize the importance of an onco-nephrology clinic in the management of the cancer patient with reduced kidney function. We will identify together the critical parameters that need to be monitored in patients with reduced kidney function receiving anti-cancer therapy, and we will elaborate together a strategy of management of the adverse effects of anti-cancer therapy in patients with reduced kidney function. So why it's important that we talk about this topic, and particularly in patients with reduced kidney function? Obviously, because AKI and CKD are common in cancer patients, and patients with CKD are more vulnerable to developing AKI. In general, the cancer patients is invulnerable to numerous and profound electrolyte disturbances, and patients with reduced kidney function often have them at baseline, and then they get more. Hypertension is extremely frequent in general in the CKD population, and more so in the cancer patients with CKD. Drug dosing can be extremely hard to determine in patients with CKD because, unfortunately, those patients often get excluded from clinical trials. And also, there is no consensus about the right method to measure the GFR in cancer patients. And so the methods used are very heterogeneous from one trial to the other. And then last but not least, decision-making can be extremely complex when you have cancer and advanced kidney disease. I'll go over first some renal toxicities of conventional chemotherapies that are mentioned in our paper. Today, the oncologist combines traditional agents that have proven efficacy in a large variety of cancer, and they are often combined with newer agents. And they have both classes, I think, would have a lot of adverse effects, and that sometimes it's hard to tease out what caused what. Hence, often the increasing role of a kidney biopsy to be able to make the accurate diagnosis. So listed in this table, the various manifestations of the traditional chemotherapies, which can go from a plain acute tubular injury to TMA. And it's important to note that some of those agents, such as pemetrexed, can cause irreversible damage. And it's important to recognize this. Most of the toxicities with traditional agents are dose-dependent, and hence the importance of measuring the cumulative dose and paying attention to that. In contrast, the renal toxicities of targeted therapies are not necessarily dose-dependent, but have been noted to happen in several weeks after they're started, most of the time. They're also very variable. We, of course, all are familiar with the hypomagnesemia, for instance, that can happen with EGFR inhibitors. the fact that anti-VEGF agents can notoriously cause hypertension and proteinuria, but also TMA. And it's often delicate sometimes to biopsy those patients. Same thing with tyrosine kinase inhibitor that notoriously can cause hypertension and proteinuria, but also FSGS and interstitial nephritis. And then it's important also to recognize the cancer immunotherapy toxicities with precisely PD-1 and PD-L1 causing in a very large majority of cases interstitial nephritis, but also other injuries. And specifically, many cases of glomerular disease have been reported with those agents. And again, the importance of kidney biopsy is important there. But also with CAR T cells, capillary leak syndrome can be a major problem. Hence the importance of preceding this therapy by decreasing the burden of the tumor as much as possible. Other drugs are also mentioned in our papers. So it's not just about the anti-cancer therapy, but also about the supportive therapy that's given often to those patients, and most importantly, biphosphonate. In an onco-nephrology clinic, it's extremely important to monitor the patient for many parameters. Some of them include electrolytes, blood pressure, proteinuria, and fluid retention. Laura Cosmai from Italy published a very nice paper a few years ago that I all invite you to read, with general guidance about how to start an onco-nephrology clinic, how to run it, and how to really assess whether it's making a difference in a cancer center through quality parameters. And she lists in this table the many parameters that one could manage in an onco-nephrology clinic. As you can see, it's a comprehensive clinic where not only we manage renal adverse events from anti-cancer therapy, but also renal complications from the cancer itself, or other diagnostic and therapeutic procedures done for the cancer. And importantly, the population of transplant patients is a particular population where there is unfortunately not much data, and hence, a multidisciplinary management of these patients is critical. So it's extremely important and essential to do a kidney health assessment of the patient with cancer. And that health assessment is about the patient, is about its kidney, and is about its cancer. Regarding the patient, evaluating and managing as much as possible comorbidities and previous CKD and optimizing their current state is important to minimize effects of the potential treatment. Hypertension and glycemia control of patients with diabetes is critical. And of course, reviewing the treatments that he's currently receiving before he undergoes any cancer-related therapy to measure and estimate the potential interaction that could occur. Renal function tests can be through an estimated GFR, but in certain cases, a measured GFR can really be essential in that sense, especially when you have reduced kidney function, when the current equations are not very accurate and don't work when the patient is not in steady state. Electrolytes measurement should not only include a traditional basic metabolic panel, but should also have calcium, magnesium, and phosphorus part of them. And then, of course, the acid-base status, the uric acid level, and the LDH. And that's because cancer patients do have a very large display of electrolyte abnormalities. The most notorious and the most frequent are hyponatremia and hypercalcemia, but it's important to recognize the importance of screening for hypomagnesemia that can occur through the therapy, but also through cancer-associated vomiting and diarrhea, and can lead by itself to hypokalemia and to worsening hypokalemia and worsening hypocalcemia, and hence the importance of measuring it. In the case of phosphorus, you can have hypophosphatemia through decreased dietary intake and tumor osteomalacia, but you can also have hyperphosphatemia when the patient has AKI CKD, hence the importance of having a phosphorus level at baseline. I'll go over very briefly some important concepts regarding hyponatremia and hypercalcemia. Hyponatremia is important to detect early and treat because it's associated with a decreased survival, with increased healthcare costs, with increased lengths of hospital stay, with the duration of cancer remission, and also with response to chemotherapy. Its etiologies can be very varied. It's important to try to identify all of them in order to not just, for instance, install PO fluid restriction, but give IV fluids in the cases of tubular losses, for instance, induced by cisplatin, and also recognize that a lot of the newer therapies can notoriously cause endocrinopathies. And the syndrome of inappropriate antidiuresis in cancer patients doesn't only occur because of the malignancy, obviously, but can also occur because of concomitant infections, because of pain, because of nausea, and it's important to address all these parameters. It's also important to recognize that it's not necessarily just associated with increased ADH release, but also increasingly with increased effect of ADH. And obviously, the more profound the natremia is, the more difficult it is to treat and the more multifactorial it is likely to be. And hence the importance to identify all the potential factors and address them. For instance, in the case of cancer immunotherapy, the mechanism can be very varied, and it's always important to check a TSH and to identify any potential hypophysitis or adrenalitis. And in the case of CAR T-cell therapy, obviously hypovolemia plays a major role. Regarding hypercalcemia, so again, several factors can concur at the same time. One could easily postulate that cancer being an important inflammatory condition, cytokines are always involved. Ideally, in the case of severe hypercalcemia, the patient should receive more than one therapy. Denosumab mainly targets the receptor activator of the nuclear factor kappa beta ligand, which is geared at the pre-osteoclast, while biphosphonate mainly target osteoclast. And it's important to try to identify the mechanism because obviously beside IV fluids, which should be given very promptly, depending on the underlying pathophysiology, steroids might be helpful or not, and calcimimetics might be helpful or not, in addition to biphosphonate and denosumab. Knowing that, unfortunately, because of the lack of data, there are no solid guidelines addressing the dosing of those medications in patients with reduced kidney function. And notoriously, the latest hypercalcemia guidelines that were released by the Endocrine Society don't mention at all drug dosing in patients with reduced kidney function. Hence, we're often reduced, or most centers are often reduced to just give denosumab, which, as we know, is associated with profound hypocalcemia in patients with decreased kidney function, but also hypomagnesemia, and it's important to measure and monitor both. Some tumor types that are very commonly associated with PTHrP production include the most common cancers, which are breast cancers and lung cancers, but also non-Hodgkin lymphoma and other hematologic malignancies. Also, it's extremely essential to measure a blood pressure at baseline and then monitor the blood pressure of those patients, because the armatorium of medication that cause hypertension in those patients keeps on increasing, and mostly VEGF signaling pathway inhibitors, which, depending on the series of patient studies, can cause hypertension in up to 90% of the patients, but also other drug classes, of which we think less frequently, do cause hypertension, and they include cyclophosphamide, ifosfamide, cisplatin, carboplatin, oxaliplatin. The mechanism of hypertension related to anti-cancer therapy is very, very variable from one agent to the other. It's obvious that if an agent is nephrotoxic, as a result, very often there will be treatment-related hypertension, but some agents cause also vascular remodeling, such as VEGF inhibitor, endothelial dysfunction, vasoconstriction, and sodium retention, such as VEGF inhibitors and glucocorticoids and anti-androgens. Hence, oncohypertension is an emerging specialty on its own, and that's because hypertension and cancer are closely linked. Observational studies have shown an increased risk of developing cancer. Antihypertensives have also been linked to cancer risks, such as thiazide diuretics. And then you could have paraneoplastic hypertension, anti-cancer agents, as I showed you, causing hypertension, but also adjuvant therapies that come with the cancer, such as NSAIDs, steroids, calcineurin inhibitors, apoietin, and anti-androgens. There has been a set of guidelines to try to optimize the management of those patients. They rely on some data regarding the preferential use of CCB, ACE, ARB for patients receiving VEGF inhibitors, but also they stress on the importance to tailor your blood pressure management to the comorbidities that the patient has. This obviously requires a multidisciplinary approach that would involve physicians, pharmacists, and support staff. Edema in the cancer patient can be increasingly bothersome to the patient. I'm sure you've all had patients for which it has incredibly affected the quality of life and caused a lot of distress. It's also important to recognize that often the etiology is multifactorial and that diuretics don't solve everything, and that the armatorium of drug that cause edema includes anti-cancer therapies, but also a lot of the supportive therapy that's given to those patients. And notoriously antidepressants, for instance, such as escitalopram, analgesics such as gabapentin, and of course, NSAIDs and corticosteroids. The mechanism is related to lymphedema, to permeability, an increase in the permeability of the vessels, and to vasodilation, in addition to the nephrotoxicity of many medications. Hence, it's extremely essential to assess the intravascular blood volume before giving loop diuretics and try as much as possible to address lymphatic insufficiency, arterial vasodilation, and increased capillary permeability through reviewing all the potential medications that would cause it and stopping whatever is possible to stop. But mostly important, in my opinion, is to really reassure the patient and accept a certain degree of edema that, unfortunately, with the polypharmacy that the patient is going to receive, is almost inevitable. I'm going to give now the rest of this presentation to Jolanta to pursue. Thank you.
Thanks a lot, Sabine. And then I will continue on the, I would say, also very important part of our paper. As we discussed previously before, the paper was even in the development stage, that the very important part is also when to stop the drug. and try to find the risk and benefit acceptable for both sides. Oncologists use the term common terminology criteria for adverse event, and the current version was released some time ago, and there should be also, of course, an update. It uses a range of grades from 1 to 5, and the specific conditions and symptoms may have values or just descriptive comment, but the general guideline is like 1 mild, 2 moderate, 3 severe, 4 life-threatening, needing urgent intervention, and 5 it's death related to adverse events. And concerning the specific adverse events related to the kidneys, as for CKD, the grade 1 is just eGFR or creatinine clearance below 60 milliliters, or proteinuria +2 present, or urine protein and creatinine ratio more than 0.5. For grade 2, I mean moderate, is GFR between 30 and 59, or creatinine clearance. For grade 3 is GFR below 29, so it's a grade for CKD, and the grade 4 is eGFR or creatinine clearance less than 15, or when dialysis or transplant is indicated, it's equivalent to stage 5 CKD. For AKI, the grade 3 is hospitalization indicated, and for grade 4 is life-threatening consequences when dialysis is indicated. So you can see that for nephrologists, it's not equal eGFR and creatinine clearance. Concerning the antivascular endothelial growth factor therapy, and when we're talking about the proteinuria, it might be also the reason when we need or think about the drug withdrawal. Concerning the agents targeting VEGF and VEGFR receptors, so we do know that it's not only bevacizumab, but also aflibercept, sunitinib, pazopanib, axitinib, ramucirumab, and also other multikinase inhibitors. With the proteinuria, it is also a quite common adverse event for mTOR inhibitors, temsirolimus, everolimus. As we can see on this particular slide, you see the normal podocyte in three-dimensional version, and then you see the same podocyte after bevacizumab administration. So what is really striking that this podocyte looked abnormal with face-foot effacements, and that's why we can explain why we do have protein in the urine, and it's also due to the endothelial injury. However, when it comes to the guidelines, what shall we do when proteinuria appeared while on anti-angiogenic therapy? Generally, there are no guidelines. It is suggested to temporarily withdraw bevacizumab if the 24 hours proteinuria levels exceed 2 grams for a daily, and permanently discontinue if it's in the nephrotic range, so more than 3.5 grams daily. Pazopanib should be discontinued at the protein level of more than 3 grams per 24 hours collection or higher, but there are no guidelines for other TKIs. And in generally, the first question arises that we have to have the baseline urinalysis, and if we are talking about the 24 hours urine collection, also it should be stressed that this 24 hours urine collection should be performed in appropriate way. Just 24 hours, not 20 hours, not 21 hours, and it should be a really complete collection. From nephrological perspective, we know that it's cumbersome, it takes time, and sometimes with other activities of patients, this collection is generally not complete or not appropriate. So that's why it's some kind of, I would say, the weak point. In generally, the withdrawal of the offending drug leads to a significant reduction in proteinuria. However, it may also persist. And what is, I would say, the drawback that we do not have the specific therapy. We administered renin-angiotensin system blockade to lower intraglomerular pressure. It may reduce protein excretion. However, it not always worked as we would expect. So this is kind of a scheme that targeted therapy, they can cause, as Sabine showed, electrolyte disorders, hypertension, but also proteinuria. And also I will talk about a little bit different problems and what to do with the drugs. So this is kind of a summary. How frequent is proteinuria and also drug-induced TMA associated with VEGF and TKI agents use? So you can see that there are several papers and several pathologies. However, as we can see that it's also quite inconsistent. Like with bevacizumab or TKIs is in metastatic renal cell carcinoma, proteinuria could range from 20% to more than 2/3. Whereas the proteinuria stage 3 or 4, or why it's defined as 3+ in dipstick or more than 3.5 gram daily or nephrotic syndrome, it was only found in 6.5%. With aflibercept, proteinuria was observed in 62% treated with aflibercept and chemotherapy versus 31% treated only with chemotherapy. So it is still a high number of patients with proteinuria. With ramucirumab, the proteinuria was less often, like 10%. In regorafenib, less than 10% in one study and only 1% in stage 3 or 4. So as we can see that the range of proteinuria, it's variable. It's also the matter of a definition, and also it's a matter also when we look at the 24 hours protein excretion or just the dipstick proteinuria. The risk factors for proteinuria is in general prior chronic kidney disease, prior proteinuria and hypertension, or renal cell carcinoma. Concerning mTOR inhibitors, what we did see in the transplant setting, that in both sirolimus or everolimus, we experienced proteinuria. In oncology, temsirolimus also used. And note what we would like to stress, that in cancer patients, everolimus is administered at 10 milligram per day, so dose which is much higher than in the kidney transplantation settings. However, no serum dosage is usually performed, and no serum normal range is being available in cancer patients. So that's why it's very difficult to translate our data from the transplant setting into the oncology world. And also, as we can see from this particular table, the everolimus can cause either increased serum creatinine, hypophosphatemia, hypocalcemia, and also the percentage is quite high, like starting from 50% in overall increased serum creatinine, and with temsirolimus, it was 14%. However, in the retrospective study, the incidence of proteinuria was 96% in metastatic renal cell cancer treated with everolimus. So it's really quite a lot. So that's why it's still the matter of debate. In a transplant setting, we do withdraw the offending drug, I mean mTOR inhibitor, due to proteinuria, because in general, we cannot deal with that, even with a RAS blockade or other antiproteinuric treatment. Another one setting, clinical setting, is drug-induced TMA, and in patients treated with anti-VEGF therapy, there may be the dual effect on the endothelium. dysregulation of VEGF receptor 2 pathway, or dysregulation and or of complement factor H activity. There are also some certain drugs which are known that may induce thrombotic microangiopathy. And these drugs include gemcitabine, mitomycin, pentostatin, vincristine, proteasome inhibitors, and also vascular endothelial growth factor signaling pathway inhibitors. Concerning the management, we are talking about the drug discontinuation and supportive care, platelet transfusion for clinically significant bleeding, dialysis if indicated, dose reduction of nephrotoxic chemotherapeutic agents. However, it is critical to withdraw the offending drug, as drug-induced TMA can be fatal. Concerning the immune checkpoint inhibitors, we can experience AKI, secondary to acute tubular interstitial nephritis. And in this moment, drug should be discontinued and systemic steroid therapy is introduced. How often, as we, as oncologists, not nephrologists, as oncologists, administer this drug more and more frequently in a different settings, we're learning a lot that the renal complication could be acute interstitial nephritis in both anti-CTLA-4, so we can see the biopsy-proven cases, and also we can see like minimal change disease. As well as with anti-PDA agents, like in this particular case series treated with nivolumab. It was AKI in a clinical setting, but on the biopsy, it was acute interstitial nephritis. We also can see different glomerular pathologies like minimal change disease, IgA nephropathy, FSGS, membranous glomerulonephritis, and also other AKIs. The incidence right now is defined like, let's say, below 10%, and in particular with the combo therapy like ipilimumab and nivolumab, it's usually much higher in comparison with monotherapy with either of these agents. And coming to I would say summary, the kidney supportive care introduced symptom management from the physical, psychological, and also spiritual and existential part. There is also expert communication like prognosis sharing, shared decision-making, advanced care planning, multidisciplinary team support, nephrologists, palliative care specialists, nurse, dietitian, chaplain, and the social worker. And also, we should discuss option of comprehensive conservative care, continue CKD care without dialysis, maximize quality and quantity of life, and finally, end of life care, optimal use of hospice, maximize dignity, and bereavement support. And as Sabine mentioned about the Laura Kosmai and co-workers papers concerning establishment of onco-nephrology clinic, in this particular setting, we also look at the indicator of performance, like percentage of patients discussed by the core team, percentage of patients brought to attention of the multidisciplinary team, number of episodes of AKI from anti-cancer treatment, number of episodes of contrast-induced nephropathy, number of visits to emergency ward due to kidney toxicity from oncological treatments, number of hospital admissions due to kidney toxicity, number of treatment interruptions due to kidney toxicity, number of treatment withdrawals due to kidney toxicity, number of drug-related adverse reactions due to kidney disease. And last but not least, but it is really important, patient satisfaction and healthcare worker satisfaction. And finally, this is our almost last slide, that in the multidisciplinary team, the quality of provided health care should not be inversely related to the number of participating specialists. And the good physician treats the disease, but the great physician treats the patient who has the disease. And now, at the end of the lecture, he allows some time for questions, but someday he allows also sometimes for answers. Thank you so much.
Thanks so much. This was really great and very comprehensive. So, Jörg.
Thank you very much for this really comprehensive paper and comprehensive review, and the nice talk which sums it all up. So, but I have some questions. First one is like, if we as an oncologist start to discuss a strategy with the patients, there's usually one question in the beginning, if the treatment is like curative or palliative, of course, and then we look for organ dysfunction, and kidney function, of course, is a concern for us always, yeah? And so, but I want to ask about the estimation of kidney function, because the regulatory authorities like the FDA always recommend to measure Cockcroft-Gault formula, which is a rather old one, I suppose. And we have the new ones like the CKD EPI formula or cystatin. So what do you recommend if I have to assess kidney function?
So you're opening a book of worms here. So first of all, the FDA is actually revising all the recommendations, and there is a very important document that was elaborated by Thomas Nolan recently, and that probably is still unknown from the public, where he elaborates a lot on that issue. Regarding the Cockcroft-Gault equation, it's probably still very much used and recommended, because when a lot of the older anti-cancer agents were developed, this is all what was available. But we all know its limitation. We all know it's not accurate. And what's more dangerous is when an oncologist looks at the estimated GFR reported for a patient, which occurs automatically in many centers over the world, in the EMR of the patient, but then looks at the manual to dose the medication with the Cockcroft-Gault equation. And the eGFR would have been reported using, for instance, the CKD epi in all instances, and I'm not sure how much also the European equation is now used in Europe automatically in certain centers. But then the Cockcroft-Gault is a measure of creatinine clearance and is an estimate of a creatinine clearance. And creatinine clearance is not synonymous of GFR. So hence the increased confusion and the inaccurate dosing of medications. And for instance, there is a paper that was just published in JAMA talking about how heterogeneous are the methods of estimation of kidney function all over the cancer trials. And this adds even more to the complexity of the issue and to how much those patients are at risk of getting inaccurate dosing of their medications. And sometimes even to be they're excluded or included of the trial because their kidney function is not estimated accurately.
No, that's the point. I mean, we had the same discussion with weight, actually, and dose capping if your body surface area is above 2 square meters. So we see in rather large trials with women with breast cancer, that dose capping in adjuvant curative setting is not good and should be abandoned. And in palliative care, of course, where we avoid toxicity, dose capping is a good idea. So I think the same is true for kidney function. As exact as it is, it should be the best to have. And what about cystatin C clearance? I mean, we have some problems as we give lots of steroids, and I think cystatin C is increased by steroids. That is right, yeah?
It's increased with steroids, and it's also impaired by inflammation. So it's also not a perfect marker. But and I invite you to read a position statement that was issued by the American Society of Onco-Nephrology, and of which I was part, which went over all the data present so far about in cancer patients about kidney function estimation. The conclusion of this said that, nothing works except measuring the GFR. But if you don't have this at your disposal, and obviously it's not practical to do it every day, probably so far the most accurate equation for cancer patients would be eGFR using a combination of creatinine and cystatin C.
Yeah.
Keeping in mind that this equation, as you pointed out, was not very accurate at extremes of body weights. is not accurate at very low GFR, and shouldn't be used when the patient is not in steady state.
And also there is one more situation that we have to think about the using of cystatin C. I know maybe the term is not perfect. It's called pseudo AKI, like after certain drugs like PARP inhibitors, the rise in serum creatinine might be seen, but it's the matter of the competition at the transport part in the tubule. So in this particular moment, we need to, when there is a rise in serum creatinine, we need to use cystatin C to prove that it is not true worsening of a kidney function. So this is the real, I would say, achievement in the last years, I would tell.
And what about new markers? We measure this DCOP3 already in the urine to check if patients are at risk for AKI. Could that be recommended? Do you have an opinion on that?
Well, honestly, I was working in the field of the AKI biomarkers for many years, and at the very first moment, all of them are extremely promising. Later on, they are coming to be disappointing, and then we are coming to the real world. And in the real world right now, we do not have, I would say, the standardized and validated biomarkers. For the research part, they are really excellent, but I think we'll need much more time in the validation cohort.
To identify patients at risk, maybe with DKK3. Okay. Another point is that medications which are good for kidneys, like ACE inhibitors and good for the heart, like beta blockers, they are also good for our cancer patients. So how would you recommend to be really generous to prescribe these drugs? Like ACE inhibitors can prevent proteinuria, maybe they can prevent some heart failure. Same for beta blockers, at least for the heart failure. So I think we should be more like do internal medicine and recommend these drugs. Yeah.
Absolutely, yes, because there are, I would say, drug with long-term proven effectiveness as a nephroprotective drugs, and also there are many studies also in oncology proving that use of beta blockers, they prevent the development of heart failure. So for us, we should not, I would say, withdraw this drug or should not be afraid. Of course, like ACE inhibitors or ARBs, we have to bear in mind that they might increase the risk of hypercalcemia, but it's just a matter more of discussion of the diet and concomitant medications, not to withdraw this particular cardio and nephroprotective drugs.
Yeah, but oncologists take a lot of blood samples, so we usually detect the problems occurring from medication. And another thing is about what I thought about is this reversibility. So some of these kidney dysfunctions you mentioned are quite reversible. For example, like immunotherapies or CAR T-cell therapies, these are regular like septic or hypovolemic problems which can be easily treated. But there are others which are very severe affections of the kidneys, like cisplatin, which can cause permanent and irreversible kidney dysfunction. I was a bit missing that to see which kidney failures are like very dangerous because they are irreversible, and others which are like can happen, but they usually are by steroids, volume and everything are easily reversed. So yeah, can you comment on that? Which are the really bad ones which don't come, where the kidney do not recover?
Well, in general, as you told that platinum derivatives, we know that the kidney failure is usually irreversible and progressive. And with the old drugs, we generally have this, I would say, the widespread knowledge about that. So we try to prevent as much as we can with a good hydration and withdrawal of concomitant potentially offending medications. I cannot say nephrotoxic like NSAIDs because they deal with hemodynamics of the kidney. However, with the new drugs, like with ICIs, we still do learn. We know that steroids work perfectly well, and the effect should be within 2 to 3 days. I mean, say the amelioration of the kidney function.
Okay, what do you think about this? This is in practice care. one of the problems is with proteinuria screening. So at the beginning, we do a spot urine and see if there's some proteinuria or not, but then further on, and sometimes the development of these side effects take rather time. Like in immunotherapies, we can see like 3 months later that the problems occur. So what frequency of proteinuria screening would you recommend?
Well, that's a very good point. And Jolanta and I are part of an ADKI work group, which is going to come with a consensus statement about this. Proteinuria is extremely important to measure at baseline, as you pointed out, because the patient could have significant proteinuria at baseline that has not been detected from other etiologies, like diabetes, for instance, being very common in this population of patients, but also sometimes due to paraneoplastic disease. And then you could have proteinuria induced by the medication. Some of them can be, it can occur quite early in the treatment, but it can occur at any time. And so we would advocate to really have proteinuria measurement at the same time as you have basic metabolic panel management for those patients.
3 weeks would be usually in treatment, like cycles of 3 weeks, we would check that, yeah?
Right, and every time, you know, you have some proteinuria that of which the etiology is not readily obvious, a kidney biopsy is always important to tease out. And we're still learning a lot in that field because, you know, there is a lot of reports of associated glomerular disease with certain drugs. But at the end of the day, a lot of this is association, is in the realm of case reports. And we're still trying to tease out the association versus the causality versus the reversibility.
Okay. One rather special questions, but these patients come more often in our practice. Like we have many successfully kidney transplanted patients, and then they develop cancer. And one thing is estimated on kidney function, what chemotherapy they can get. I think this is a rather easy question for us. But the other one is immunotherapies. So what would you advise us to like, maybe what about immunosuppression, loss of kidney, and all these problems? What would you advise, or what would you recommend? If you have like a patient with kidney transplant and melanoma, and he has to get nivo-ipi, yeah.
Absolutely. So, and this also, by the way, applies to patients who have autoimmune disease and are already on also therapy for their autoimmune disease. And this is where it gets sometimes extremely complex and complicated, and where the expertise of a transplant physician with the general nephrologist, with the oncologist are essential, knowing that, again, a lot of what we do in practice is unfortunately very much driven by expert opinion and trial and error with no very solid data so far.
Yeah.
If I just may add something, if it's life-saving therapy, well, the transplanted kidney, we have as a backup dialysis treatment. So that's why we have to, first of all, to discuss, because as we do now with immune checkpoint inhibitors, the rate of acute rejection is quite high. But we have to discuss I would say, the benefits and the risk ratio. It's a little bit different in patients with other solid organs like liver, heart, or lung. With a kidney, I think that it's a little bit easier to discuss having dialysis treatment as a backup.
Yeah, I think the effects of the immunotherapy, especially melanoma, are so good. We shouldn't just because of this dialysis treatment should postpone that. Yeah, that's my opinion as well.
Totally.
Okay. So I'm a little bit running out of questions, actually. There would be very special ones, which may be not so interesting. So thank you very much for this good, very, very well answered questions. Yeah.
So Jörg actually took away all the questions actually I thought about. We have recently published a paper in bladder cancer patients looking at cisplatin eligibility. And basically what we found is that those patients with a GFR between 40 and 60, if measured by Cockcroft Gold, 80% of them were eligible for cisplatin based on a measured GFR. So it's really substantial, I would say, just as a comment. Very independent point. What do you do with your patient if they report impaired quality of life? Do you have a specialized program that they are getting exercise with a physiotherapy or something like that to improve that?
Excellent point. I always think that, if we can't cure the patient, we have at least a duty to improve their quality of life. And this is a substantial part of my clinic. And this is what I tell the patients often. I tell, the oncologist is there to give you the curative, the palliative treatment. I'm here practically to hopefully try to take care of everything else. And that involves all the aspects of internal medicine that can impact or are impacted by kidney health, but also first and foremost, the quality of life. And certainly exercise, good nutrition. And this is where it's extremely unrealistic to try to even think about a renal diet for those patients, is an important part of any onco-nephrology clinic.
And also crucial is a family support and psychological support.
I have two questions from my part. So the first would be with regard to proteinuria. You recommended to do 24-hour collections, and you stated at the same time it's very difficult and many patients are not really ready to do them. So why don't you use spot urine like we do outside of onco-nephrology regularly nowadays?
Generally, I think it was a huge discussion right now at ADKI meeting that we should advocate for using spot urine. However, we also do know that in some certain oncological or hematological protocols is a 24-hour urine collection. But it would be like with a GFR, we should advocate for, I would say, the same standard everywhere. So measure GFR, not Cockcroft Gold, because it's a little bit archaic with all the limitations, and also to use the spot urine, and if possible, UACR.
And with regard to the GFR, so if one uses the new equations, which always are indexed to body surface area, giving us the GFR as milliliters per minute per 1.73 square meters, when it comes to dosing of treatments, then you would have to de-index this to get the real GFR, or how would you recommend us to do if we use these equations?
I think it's just a matter, like we discussed in the ADKI meeting, that there's a message to work together with oncologists and hematologists to use completely the same equation. And then, because the drugs, in particular the old drugs, they were registered using Cockcroft Gold, the leaflets should be also changed. And this is a huge work ahead of us.
And one final question from me, sorry. So what about EPO? And the question actually goes to all of you, to the three of you. So we are always reluctant on the one hand to give EPO to patients with cancer because we might be afraid that this may stimulate further cancer growth. At the other hand, we see that our patients have sometimes really severe anemia, and we really want to avoid blood transfusions. So how should we proceed in these cases?
So this is a very important question. And I would say nephrologists usually are more reluctant than oncologists at using them. And the problem most of the time comes from nephrologists, not oncologists. So I would say, and I will leave my colleague from oncology to answer this, I would say it certainly depends on a large number of factors. One of them would be, are you giving the chemo for curative intent or for palliative intent? The other point, which I find extremely important, is that we assume that those patients will only respond to EPO and to very high doses of EPO if they have severe anemia. We forget often that sometimes they have simple deficiencies because of nutritional deficiencies, and it's important to address those and not have the phobia of giving IV iron in those patients. But I will let Professor Bitten speak further on this.
Yeah, we have. So in Germany, we are usually hematologists and oncologists. So we have both, see both sides of the story. So, so we check for nutritional deficiencies first, and then I think it depends on the resources. So we are a clinic with very good resources for blood products, and we can easily, within 2 hours, give blood products. So we are very prone to give blood products to our patients. We have very low prescription rates for ESRs, but for ESAs. So, but we would recommend in a resource, or if patients have to have long travel ways to the clinic in resource low situations, I would recommend to all palliative care patients with anemia, where you don't have any infection or inflammation which you can correct, that you give erythropoietins. Yeah, that's a good choice to maintain the hemoglobin level for a longer time. But still, I think most of the cancer patients need transfusions. Yeah.
It's completely the same in our everyday experience, that the oncology hematology has very strict guidelines where we can consider ESA therapy. In generally, we ended up in blood transfusion, iron, and then like anemia due to chemotherapy or MDS. This is the way to prescribed erythropoietin stimulating agents.
Yeah. And we have learned a lot in that field. We have now like the inhibin inhibitors, so we can like do ESAs and this luspatercept. So we have both sides of the erythropoiesis to stimulate, and this can maintain very good levels of hemoglobin in some MDS patients. Yeah.
Yeah.
So thanks so much. This was really brilliant. We are at the end of a great academic hour. Thanks for taking the time, for being our guest, and surely much more thanks for moving this field, which I guess becomes more and more important for both oncologists and for nephrologists. Thank you. Have a nice evening.
Thank you for having us.
So
Danke.